Good afternoon, everyone. It's my great privilege to welcome you to the third lecture of Aarogya Health Lecture Series, an initiative by IIT Delhi Hospital and the Office of Academic Outreach, fostering for awareness of preventive healthcare and encouraging meaningful discussions on healthcare and well-being. This series brings together the leading experts from the medical field to share their evidence-based knowledge on the important health topics. And today's session will focus on the cataract, how it is caused, and to watch for the early signs that we need to be careful about. Additionally, we'll learn about some simple lifestyle techniques that will help us to prevent or delay this cataract and also explore the latest treatment options available, starting from the traditional surgery to the advanced laser techniques and premium lenses. Today, we are honored to have with us Dr. Amit Khosla, Senior Consultant and Co-Chairman of the Department of Ophthalmology at Sir Ganga Ram Hospital, New Delhi. Dr. Khosla is an esteemed figure in the field of eye care and surgery, known for his work in advanced treatment and intraocular lens transplantations. As we proceed, it's my honor to invite Dr. Mahesh Sagar, Head of IIT Delhi Hospital Services, to formally introduce our distinguished speaker for today's session. Dr. Sagar has been instrumental in strengthening healthcare services at IIT Delhi Hospital and guiding us for this initiative. Dr. Sagar.
Good afternoon, esteemed guests, colleagues, and participants. A warm welcome to the third session of Aarogya Health Lecture Series, an initiative by IIT Delhi Hospital, the Academic Outreach Office, aimed at promoting awareness of the preventive healthcare and facilitating evidence-based discussion on critical health issues. Today, we are privileged to host one of India's most accomplished ophthalmologists, whose surgical skill and academic contributions have redefined excellence in eye care. Allow me to introduce Dr. Amit Khosla, a visionary clinician, revered academician, and a pioneering surgeon who has transformed countless lives through his expertise. He completed his MBBS from Maulana Azad Medical College, New Delhi, and pursued post-graduation in ophthalmology from Dr. RP Center, AIMS. During his post-graduation, he received the Best Resident Award. He completed his senior residency at AIMS, specializing in cataract, retina, uvea, and ocular trauma. Dr. Khosla has contributed chapters to various ophthalmology textbooks and has published extensively in national and international index journals. He also serves on editorial boards and review panels of several reputed ophthalmology journals. He has been a thesis guide, co-guide for more than 25 postgraduate students pursuing their DNB, and is currently the teaching coordinator for FNB, that is Fellowship of National Board in Retina. He was a member of Academic Research Committee and the Scientific Committee of All India Ophthalmology Society, and he has been Secretary of Delhi Ophthalmology Society too. As the Secretary of the Society, he started a postgraduate teaching program to standardize PG teaching across the country, and for the first time had lectures available on social media. He is considered a pioneer in management of uveitis, that is ocular inflammation. He pioneered the use of biological drugs in uveitis, which are used for rheumatological diseases too. He was invited by the Indian Journal of Ophthalmology to write a review article on immunosuppressive therapy for uveitis in developing world. He has started the concept of combining clinics with rheumatologists, the first in country for managing eye diseases and rheumatology. He also was among the pioneers in management of retinopathy of prematurity, a retina disease in preterm children. He has been invited to be part of international collaborative study to classify ocular TB CON study, which has been published in prestigious American Journal of Ophthalmology. Dr. Khosla will be speaking on cataract and the available treatment options. Please join me in giving a round of applause to welcome Dr. Amit Khosla, who will now take us on an enlightening journey to the world of modern cataract management. Dr. Amit Khosla.
Good evening, everybody. I think it's easy for me to explain because half of ophthalmology is optics, and more better than engineering students and faculty to understand what we want to say. So this is cataract. the lens of the eye. So the eye has two lenses, the cornea and the lens. So the cornea, the transparent cornea has power about 44 diopters, while the intraocular lens has a power of about 18 diopters. So the main focus is from the cornea. Lens has a variable. So what is cataract? Cataract is opacification of the lens with age. So we have two structures in the eye which has no blood vessel, that is the cornea and the lens. So when they age, there's no way for the cells to be destroyed. They keep accumulating there. So the lens is like an onion. It keeps expanding with each layer. It keeps expanding, and there's no place for the cells to get destroyed and go away. And so we are accumulating all the dead cells inside. So with time, it tends to become thicker, opacified, less transparent to light with age. So if you have a 20-year-old person or a 40-year-old person, they will feel different brightness. So with age, your contrast keeps going down because the transparency of the lens goes down. So here's a small video which I'll show what the eye is. So the eye has this lens which is malleable, which can focus. So we have an autofocus system where the light can be focused, and you can autofocus zoom in at distance or near. So a normal eye at birth is about 18 millimeters. By adult, it has a 24 millimeter size of length. So if your eyeball is bigger in size, more than 24, then you will require minus lens myopia to correct. And if your size is less than 24 millimeter, you require it's hypermetropia, require plus lens to this thing. And when you want to focus near, these muscles relax, changing the shape of the lens and able to focus. So light is focused on the retina. So the eye does not have vision. It is just a capturing device. The retina captures, transmits the signal to the optic to the brain, and the brain analyzes it. So a lot of people have misconception that the lens has the vision. The lens is only a focusing device. So the most important part of your eye is the retina, which is attached to the brain. So retina is the default part of the brain because it's a single neuron connecting to the brain. So with age, the lens opacifies, becomes color, so you see different colors. With time, you will brightness and contrast, you will see more darker colors. So the visual pathway, as I mentioned, is the cornea, then focuses to the lens and hits the retina and the optic nerve. So lens is like a zoom lens, retina is the image sensor, the brain is the image sensor, and the IOL can replace a lens. It's just a small part of the whole system. So lens is not the important part. And with aging, all your system will wear out. So what has happened with aging? The lens stiffens so that you could focus near, but after 40, you need glasses to focus near to read. That's called presbyopia. So with age, your focal point keeps going back and you need a magnifying glass to see. So you need lenses to focus nearer. The lens starts to cloud because the protein denatures and you develop cataract. The retina and the central area of the retina, the macula, also degenerates. The pupil shrinks and the tear production goes down. So from a physics point of view, the tear film is about 5 micron. If you have dry eyes, I will have blurred vision. If my cornea is not as transparent with age, it will create decreased vision. And then the cataract. And the retina, if it degenerates with age, it will also have reduced transmission of light. So your vision, as you age, every part of the eye will age. So it's not the cataract. A lot of people think that every vision loss after 40 is cataract, and they just go to the doctor later and they have other problems which are underdiagnosed. So every person who after 40 must visit the eye doctor, and at least once in 5 years, or ideally 2 years, get an eye checkup done. So basically the lens clouds because of the denaturation of the proteins. So what is the cause? The commonest cause is age. Is age the only factor? No. You can even be born with cataract, congenital cataract. And the commonest cause is diabetes, because what happens is every time that sugar goes up, because of osmosis, the lens retains glucose, and every time your sugar goes down, you have opacities in the lens. So a diabetic patient will have cataract 10 years earlier than a normal person. If they are twin brother sister, genetically same, one is diabetic, 10 years earlier you will have cataract. The commonest cause of acquired cataract is steroid. If you have to take steroid for arthritis or for bronchitis, if you take it for more than 1 year, you tend to develop posterior subcapsular cataracts. Anybody who's asthmatic, arthritis, skin problems, taken steroid for long duration will have early cataract. Then they say the aging occurs because of UV light. That's why you have goggles to prevent degeneration of the retina and the lens, because UV tends to decay. Like people use skin cream to prevent aging for their skin. You need goggles with UV protection for preventing this thing. Then eye injuries is a common cause for cataract. We see a lot of injuries, sports or Diwali injuries or any car accident, you have eye injuries. Genetically, you can have family history of genes and inflammation, uveitis. Any inflammation in the eye will change the metabolism and cause early cataract. But 90% is aging. That's why we saw anybody above 40, we say it is senile cataract. And before 40, we say it's pre-senile or other causes of cataract. So what are the symptoms? So basically we are taught it is a painless progressive loss of vision. There is no pain in the eye if you have cataract. If you have pain, there is some other cause of it. And it will be not sudden, it will be gradual diminution of vision. You may not know because with one eye you will be seeing properly. So you'll have blurred or cloudy vision, sensitivity to bright light because you have glare. You have difficulty seeing at night because the opacity in the lens will cause diffraction of light and glare. Then you may see halos around light. You may see multiple images, and you may see double vision. You may see multiple moon at night because then the pupil dilates, and you have different refractive index. So for one to understand, the eye is like a camera. It has an aperture. So in daytime, the pupil becomes smaller in size, and your central retina, which has the cones, has color vision and better vision. At night, you need more light, the pupil dilates, the cones don't work, the rods work, which work at night. So you have night vision, is always has less contrast colors, but your sensitivity of light, the rods become more active. So as I mentioned, the cataract is called immature if the lens is still able to transmit light. If it cannot transmit light, it is called a mature cataract where your vision goes down. And hypermature is when the proteins start to denature and the lens starts to release chemicals. If you remember that the lens has proteins. Now, in our body, my genetic code, my antibodies will be formed to foreign protein. But the lens protein is not in our software. So if the lens protein gets released into the body, it creates inflammation in the eye. Antibodies are formed to it. And the zonules on which the lens is stuck, they are fibers like a hammock, they also decay and the lens can dislocate. But now we don't wait for those times where it needs to be mature, and then we do early surgery. So how would somebody diagnose cataract? So anytime you have these visual symptoms of decreased vision, glare, please go and get your eye checked up. And we dilate the pupils to see a full lens, because only the eye lens is about 13 millimeters size, but the central lens is only 3 millimeter. Pupil size is 3 in bright light. So we are using the central 3 millimeter of the lens only. So God has made our eye to prevent aberration. As all of you know that all lenses cause spherical and chromatic aberration. So the cornea is thicker in the periphery. The lens has a different refractive index in the center. So God has made our eye to prevent chromatic and spherical aberrations. As you develop cataract, you may have, those who do optics will understand there are higher order aberrations also, like trefoil, coma. All those aberrations will start to come into your quality of vision. You may see fully inside the house, but when you go out in bright light, the aberration make your vision go down. So I tell everybody the first indication of surgery is your night driving gets affected. If you have cataract and you do night driving, you need to get early surgery done, because you may be stuck in the middle of the road, a truck slide, and you stop seeing everything. Otherwise, you may have 6/6 vision inside the house. So what do? We use an instrument called slit lamp to see the lens structure and its opacity. And we check the other parts of the eye, the retina, which should also be normal before you plan a cataract surgery. Sometimes people go to the optometrists who are not trained to see the retina, and they say, oh, it's cataract. No, dilate your pupils, check every part of the eye before you say it is only cataract. You may have two diseases simultaneously. So with aging, the nerve also becomes thin, the eye pressure goes up. So 1 in 100% after the age of 60 will develop a disease called glaucoma, where the eye pressure starts to go up and you have nerve damage. If you are diabetic, you may have changes in the retina, it's called diabetic retinopathy. So we need to evaluate all parts of the eye before we declare that it's only cataract. So normally, we see the retina. This is the color photograph of the retina. And this is the only place in the body where you can see live blood vessels. So I can tell you whether you have atherosclerosis, you have a risk to heart disease, you have changes in diabetes, you may have a kidney problem, hypertension. We can just seeing the vessels in the eye, we can predict the systemic disease. So the eye blood vessel system is a window to the body. And at the bottom, there's a photograph. This is infrared photography using the concept of ultrasound. It's called OCT. Optical coherence tomography, where we check the layers. This is just a 200 micron retina. We can see every layer of the retina. And the normal retina is thinnest here. The cones are here maximum, and we have the maximum vision here. And this is the nerve which transmits to the brain. This is the nerve which transmits signal to the brain. And if there is a swelling, the retina swells up. And this may not be seen in the normal examination. In this test, OCT helps us pick up any changes. So if somebody comes to me after 60, about 1 to 2% will have some issues of aging in the retina, which may not help vision come back to normal. So what do I if I have cataract? The first thing, rule out diabetes. That is the commonest risk factor to cataract. Once the cataract starts, you can't slow it down. A lot of medicines have been tried, but none works. And you may require change of glasses because the lens will thicken, the number will keep changing. So the definitive treatment is only surgery, and only if you're visually handicapped. So if I do surgery today or after 6 months, my result is going to be same. So just because you have a cataract doesn't important you need surgery. It's only if it's affecting your visual outcome, your profession, your independence, dependence, then you go in for surgery. As long as I tell the elderly people, if you can see your TV and mobile, you are normal. You don't need to get surgery. If you drive at night, yes, you need to get surgery done earlier. So initially what we used to do was we were removing a cataract in total. So the lens is about 13 millimeter. So we had to make an incision of big size and take out the whole lens. So, and we didn't have any 50 years ago, 70 years ago, a thick glass was given. So what happened in World War II is that Dr. Ridley in London used to see that the Spitfire plane had a canopy of PMMA. And those fighter pilots who had this foreign body in the eye would have no reaction to PMMA. And then he designed PMMA lenses. And today our lenses is plastic, we use acrylic. So what happened at the first we started using PMA lenses. Then we found that when you have a large incision, healing time is there, and the cornea becomes irregular and creates an astigmatism. This is a cylindrical power. So we wanted some technique to come in. So in came phacoemulsification, which meant that you could use an ultrasonic probe to break up the lens into pieces through a small 2.83 millimeter incision and suck out, liquefy it and take it out so that you don't have to make a large incision. But the lenses, the eye size is 13 millimeters. You need a lens of at least 6.5 millimeters. So in the dark, you don't have aberrations. So what we have made is we have a lens of 6.5 with loops. So you need to put a lens of 6.5. You can fold it into half. Acrylic can be foldable. So at least a 3 millimeter incision is required to insert the lens, which opens up and fits into the bag. So the lens is like I said, like an onion. The outer covering case is called the capsule. We make a small opening in the center and clean up the capsule, and we put a lens inside. The only problem is that this capsule is a living structure. It will thicken with time. So it's called, if it thickens, we call it posterior capsule opacification. Earlier we had a terminology called after cataract, and people used to think cataract is left behind or it's come back again. So once you've done a surgery, cataract will never come back. It's just that the capsule will opacify. Sometimes the capsule in the young people is so strong, it displaces the lens, causes fibrosis and can tilt the lens also. So we have come to small incision cataract surgery. So I'll just show an animation. So I tried to get ChatGPT to make an animation. It was off the mark of how to make a phacoemulsification. In this, we use small incisions which are sutureless, and we first dilate the pupil and we make a small circular opening. So there is a 1 in 1,000 chance that the capsule might rupture during surgery. It is weak. So the risk of any complication or adverse event is 1%. So in came, people thought that maybe laser can make a more safer opening. So in came femto laser assisted cataract surgery. But it has shown to be the risk and all are same. So though femto laser is available in the market, but the results are same. Neither insurance gives money for it, neither the American insurance, neither anybody gives it. So it's more of a marketing tool, but we are hoping the engineers will make it more safe and we can have better results. So we normally numb the eye, and sometimes we give a local injection if the patient is uncomfortable, and we make incisions into the cornea. So in cataract surgery, as I mentioned, acrylic lens, foldable lens is the standard. Now, as I mentioned that we have presbyopia. So an artificial lens will have only a single power, monofocal. You can only focus at one place. Or if there's an astigmatism in the cornea, we can create a cylindrical, a thick lens at one angle. It's called a toric lens. We can have toric lens which neutralizes the astigmatism of the eyes. It's called a toric monofocal. So in today's world, even if you are myopic having -6, I can determine what the power of the lens would be using ultrasound or infrared light. I can have formulas to say this power lens I put in the eye will have zero correction, when I can give you zero power. So a lot of people started doing clear lens extraction. Oh, I'm myopic. Why not get my lens removed, put in a lens so I have clear vision? But cataract surgery has 1 in 1,000 complications. So clear lens extraction is slightly out of vogue because there's a risk of surgery. Some people still are ready to get it done. And I'm a myope. I'm ready to accept any complication. So this is the most important step. We make a small opening called capsulorhexis. Now this opening can be made with laser or manually. So the results are same, but you'll see a lot of marketing YouTube channels saying that laser is superior. And a recently study by the European Society showed that the complication, the result at 1 year was same whether you make this opening with this thing. The remaining surgery is done by ultrasound only, called phacoemulsification. So we basically make grooves in the lens, the central nucleus, and we break it like chocolate. We make a groove and then we separate, like you can easy to break like a chocolate, and then you can suck them out. So basically we have a ultrasonic probe which is hollow and with fluid coming in. So basically we emulsify it with ultrasound and piezoelectric effect, and then we suck it out. And then we put in a foldable lens and it goes into the bag. So what can happen wrong? I can have a swelling. Every time you even make a small puncture into the eye, there is a change in the fluidics and the hemodynamics and the pressure fluctuations. So your retina can swell up, especially in diabetics after surgery. There's a small opening. If you rub your eyes for 1 week after surgery, you can have infection. So 1 in 10,000 can, or 1 in 1 lakh have infection, can lose the eye. As I mentioned, posterior capsular opacification is another problem. But 99% of people would have comfortably. So the biggest side effect of any surgery in the eye is dryness. The moment you cut any incision, the tear production goes down. So with age, anytime our tears production is down, so a lot of patients complain of gritty sensation, foreign body sensation after cataract surgery because the eye production goes down, the tear production. So we always tell all patients, please put lubricating drop pre-op, post-op, because you will feel drying symptoms. So this is a randomized controlled trial comparing femtosecond to normal conventional phaco at 12 months. The results have been no difference. So none of the insurance companies give it because they say there's no superiority of a technique which is. So as I mentioned, an intraocular lens is 6 to 6 millimeters and it's used to compensate for the refractive error. And the acrylic, now which lens should we use? Basically it's acrylic material. Silicone is slightly out of the vogue. So it can be hydrophobic or hydrophilic. The hydrophobic ones remain clearer for a long time. So hydrophobic acrylic foldable lens is the flavor of the day. Worldwide, 50% of lenses are made in India. The technology is different. You can either do spin cast or you can do lathe cut. So the spin cast, you have to have a higher technology. The Westerners use the spin cast. India, you import huge sheets of acrylic and you do a lathe cutting and you make a lens to that specific power. So all give the same good results. So as I mentioned, monofocal lenses have sharper vision, contrast, no halo curves. But in came, like I am wearing a progressive class being 40 plus, I have 3 lenses. I have a distant power, I have an intermediate power for laptop and near for reading. But to read, I cannot read like this. I have to tilt my head to read because they're only the lower segment. So a progressive glass or a bifocal glass is a compromise. So we thought, the scientists felt, can we give a multifocal IOL? So what they have started doing is they have created diffractive gratings on the central lens to create 2 images. So you can have a multifocal lens, But the problem is that the moment you create diffractive or refractive gratings, you will have a 20% brightness dimming, and you will have halos and glare. So if you go for multifocal lens and you don't want to wear glasses, you will have issues of glare. So they are marketed as premium lenses, but today even monofocal lens, if I were to get my surgery done, I would prefer to wear glasses and have 100% transmission of light than having a 88% transmission of light in my eyes. But a lot of people feel, I don't want to wear glasses, I'm happy with 10% brightness. But with aging, my contrast is going to go down, and there's no guarantee my retina may not degenerate 20 years from now. So all the premium lenses require proper centration, require our tear film, retina and cornea to remain healthy all age for it to work. If my retina becomes unhealthy, these multifocal will stop working and it will end up being a monofocal lens only. So multifocal can give me distant vision, intermediate vision for laptop, or a near vision for a book. So multifocal gives you reading and distant, doesn't give you intermediate. So what did the scientists do? They said, oh, let's create a new image. In astigmatism, if you know your optics, you have a long image. If you have a astigmatism, it's called a Sturm's conoid. So if I see here or here, it will have a depth of focus. So what they have done is that to extend the depth of focus, they have created a cylindrical power inside the lens so that you can see the laptop and the distance, but you need for reading. So we are still waiting for the ideal lens, which will give us all three corrections. And let's hope in my lifetime I get that lens. But at the moment, monofocal is superior to the other one, the extended depth of focus and multifocal. So how to choose? If I'm a professional doctor, engineer, architect, I will go for monofocal because I want perfect vision. If I drive at night, I will require a monofocal. Yes, for a person who's not a housewife who doesn't drive is the ideal person to go for a multifocal lens because the incidence of glare is going to be less. Otherwise, 10% of people have had difficulties. So a very famous film star, I won't name him, first got a LASIK surgery, cornea flattening for refractive error, didn't want to wear glasses, got a EDOF lens. This is all on the media. And the media said, botched up surgery. And that film star got it removed. Nobody was able to touch, got it changed to a monofocal lens later. So it's important to understand there's limitation of all technologies and we can't make every patient happy. So monofocal is reliable. Multifocal will give you independence from glasses. Somebody who's old, who has tremor, may want a multifocal. He says, I can't wear my glasses and take them off. So what today is the toric lens is wonderful. If you have a cylindrical power of more than 1 and it's a regular cornea, then a toric lens helps you give correction. So the right choice depends on the lifestyle, the anatomy and the expectation of the patient. I've already told you that the eye will keep drying, the pupil will become smaller, the retina optic nerve will become weak. So whenever we plan something, we have to plan for the next 20, 30 years, expecting that everybody today who doesn't have cancer or some major issues, heart attack, will cross 80. As the expectancy is going up, we are looking for people even at 90, they want to read. So I get people who are 85, 90, they can't walk, they can't hear, but they want us to give them 6x6 vision. It's a challenge for us to, the super senior citizens who want, we read, only thing we want, we should be able to read the newspaper. And with age, the aging, let's hope we can give them better vision. So remember that the lens is only a small part of the whole system. The healthy retina, tear film and nerves are crucial. And lenses cannot stop the aging. You will have aging issues. So long-term outcomes will depend on the full eye. So how is surgery performed? Normally patient lies down and under a microscope, under sterile environment, we do the surgery. And the patient is generally, eye is made numb with drops. And if the patient is anxious, we give some sleeping injection. So the patient is anti-anxiety injections. And we monitor the BP. So surgery is least stressful, but we always want that the sugar and the BPs are controlled. So post-op recovery takes about a week. So for a week after cataract surgery, we don't expect you to splash water because the wound is not fully sealed. And we don't allow a head bath. We ask them to wear protective glasses, avoid touching or rubbing, avoid weight, strenuous exercise. And some may require glasses for distance and majority will for the rear. So 612 is a vision which is required for driving. So 95% will have 612 if they have no retina issues unaided without glasses. Some people who are professionals don't want to wear glasses. So what we do, we call a mismatch. In one eye, we'll give a power for distance, and the other eye will give for reading. So if you're not wanting binocular vision, even without glasses, you can see both, called a mismatch in the lenses. So as I mentioned, nothing is safe. 1 in 400,000 infection, which is, you can lose the eye, CME, retinal swelling, more in diabetic. So I was asking Dr. Sagar, how many of the people who are registered, how many 50 plus would be hypertensive diabetic? I think it's a lifestyle disease. 30% of the population would be hypertensive or diabetic after 60 years of age. So diabetes affects the eye, changes the blood vessels, causes bleeding and leakage into the retina, and can cause blindness. So a person who's diabetic is 40 times more chance of becoming blind than a normal person. And I mentioned the posterior capsule rupture can happen, and a rare problem is if your capsule is weak, the lens while doing phacoemulsion falls onto the retina. Then as a vitreous surgeon, we have to go posteriorly and remove the lens from this thing. And as I mentioned, the only problem, if all capsule is a living structure, it will thicken and will require laser for cleaning it up. Thank you so much. The vision is a complex system, not just optics, and their performance depends on the aging of the eye as a whole. Thank you so much.
Thank you, Dr. Khosla, for that enlightening and deeply informative session. Your insights have really helped us to know the causes, symptoms, and modern treatments available in the market. And also, it's an informative and eye-opening session. Thank you so much, Dr. Khosla. As we now move on to the interactive segment of our session today, the question and answer session. This is your chance to directly engage with the expert and ask questions. Please feel free to raise your hands, and our team will bring a microphone to you. To moderate this segment, I now invite Dr. Yasmin, Chief Medical Officer, IIT Delhi, to the stage, and please welcome her and join me in the warm round of applause.
So I request all of you to put your questions forward to sir and get your doubts clear from sir, as this is the best opportunity to clear your doubts.
Sir, how does intraocular pressure affects the vision, and what is the trajectory?
So the every rod and cone has a nerve attached to it. So like a cable, TV cable, it goes into the brain from the optic nerve. As the pressure rises, the number of fibers get decayed. So with age, they also become less fibers and they get damaged. So high eye pressure damages them irreversibly. Only when about 25% of the fiber are damaged or thinned out, you will have visual symptoms. So normally the nerve fibers get damaged from the peripheral. So your peripheral vision will get constricted first, central vision will go last. So glaucoma per se has no symptom. It is a silent disease. The angle closure, one of it has pain, but generally is silent. So after 40, everybody should get, when they go for eye checkup, should get a eye pressure done. Normal pressure is 12 to 20 millimeters of mercury. If it's more than 22, we get some test done of the nerve photograph, the size of the cupping, the field test. Based on that, we diagnose glaucoma. So like in BP, my BP may be 120/80 and somebody's 150/100. And the 150/100 may have no heart disease, but at 120/80 I can have. So for it is personalized to you. So 12 to 22 is normal, but you can even have glaucoma at 18 millimeters. So if I do a routine checkup, the pressure is high, or I see the nerve looks damaged on the retina when I do the checkup, I investigate further, and then I lower the pressure by 25% to prevent degeneration of the nerve. So it is a thing called apoptosis, self-destruction of the nerve. So you basically keep the pressure low, and the other factors are that the eye circulation depends on your blood pressure. So at night, your blood pressure tends to go down, and because of the circadian rhythm, the eye pressure goes up. So nerves get damaged most at night because the perfusion is less and the eye pressure is more. Some people have a disease called sleep apnea, and where you have decreased oxygenation at night. Your tongue falls back, and so those people get higher chance of glaucoma. So all the eye blocks and the strokes happen at night when your BP is very low and that's the time people have stroke at night. Sometimes we say don't take your BP medicine at night. You may have a lowering of BP at night when you sleep. So you can lubricate. Now the most important thing is that we live in an environment which is humidity controlled. So if you're in an air conditioned environment, you will have dryness because the dryness will happen. Number two, when you work on the PC, you are blinking less. So a voluntary blink, you need to blink. Instead of 2 seconds, you're blinking at 3 seconds. If you have symptoms of dryness, you should lubricate your eye. The question is that traditionally we are taught that splash water early morning, but all the tap water has chlorine, and you know when you swim, the chlorine causes more damage. So I would suggest splash your eyes with a closed eye, so the dust and all flows away. If you have dry eyes, you need to lubricate. That's the only thing you can do. Now, what all things can cause dryness? One, that if you have mild dry, wear protective glasses. Whenever you go out, a puff of air will dry your eyes, whether it's hot or cold. Summers, you have air conditioning. The rainy season is the best because the humidity levels are high, and if you sit in the air cooled room, humidity is high, so you are comfortable. In winters, you use heaters. Have a bowl of water. Certain heaters have a bottle of water to increase the humidity. So humidity is the most important factor, followed by your blinking rate. Third is the pollution. Pollution dries the eyes, this makes the surface rough. So have protective glasses. Number 4 is that we all have some allergies. When you take anti-allergic medication like cetirizine or Allegra, it dries the nose, eyes, and mouth. So you need to lubricate eyes more when you are taking any anti-allergic medication.
हेलो
Hello.
नमस्कार डॉक्टर साहब
Please pass the mic.
डॉक्टर साहब कुछ प्रॉब्लम फेस करता हूँ आइज में, जैसे राइट साइड में कभी
हाँ जी,
अर्ली मॉर्निंग में काफी पेन हो जाता है राइट साइड में ना, एक आइज में।
ओके।
तो वो कभी भी होता है, यानी कि कुछ उसका टाइमिंग नहीं होता और वो सडनली हो जाता है उठते टाइम में, वो अर्ली मॉर्निंग में होता है जैसे ना। और अगर मैं उसको आराम से लेटा रहूंगा थोड़ी देर तो उसको नॉर्मल हो जाता है। अगर मैं उठ जाऊंगा ना तो वो काफी रेडिश हो जाती है, बिल्कुल ब्लड, यानी बिल्कुल रेड हो जाती है आइज। तो उसका क्या रीजन हो सकता है?
सो बेसिकली हमारी बॉडी की सारी नर्व्स आईज के पीछे होल होता है उसके थ्रू जाती हैं। तो दांत की नर्व, साइनस की नर्व और आई की नर्व पीछे जाएगी, तो उसे रेफर्ड पेन कहते हैं। हमारे आई के अराउंड बोन में एम्प्टी कैविटीज हैं, साइनसेस, तो जो साफ करती हैं हवा को और डस्ट को रोकती हैं। तो वो छोटी सी ओपनिंग होती है और अंदर म्यूकोजा होता है जो डस्ट को रोकता है। अगर डस्ट पोल्यूशन से वो बंद हो गया तो अंदर एयर ट्रैप हो जाती है और आपको आंख के ऊपर नीचे पेन होती है। तो आप नेजल सलाइन ड्रॉप्स डाल लीजिए, वो खुला रहेगा। तो डस्ट के कारण 50% ऑफ आई थिंक डेली है साइनोसाइटिस, तो वो क्लीन हो जाएगा। तो आपका पेन, तो सपोज आप ऑफिस में एसी में बैठे हैं, आपका नोज ब्लॉक्ड है, आप बाहर चले गए तो एयर एक्सपैंड करेगी टेम्परेचर से, तो यू विल फील पेन हेयर एंड हेयर। So early morning pain is rarely because of the eyes, but you must get your eye pressure checked up. और जो एलर्जीज होती हैं, अगर मुझे पोलन ग्रेन एलर्जी है मार्च अक्टूबर, ये डस्ट से है, तो 4 एलर्जीज होंगी। नोज ब्लॉक्ड होगा, मेरा आईज रेड होंगी, ड्राइनेस होगी। नंबर 3 मुझे ब्रोंकाइटिस होगा या स्किन की प्रॉब्लम होगी, इचिंग होगी। तो एलर्जी कैन मैनिफेस्ट इन ऑन ई 4। आप बच्चों में देखेंगे, ये कम छोटे बच्चों में फ्लावर्स टच करते हैं और सडनली उनको एलर्जी, touch the pollen grains, they break the flowers, and they come with bronchitis, they come with eye itching, they come with nose block. So I always say, if you have a blocked nose, you sleep with an open mouth, at raat ko snore karte hain, your nose is blocked, you will have pain around the eyes. So you need a both ENT and eye checkup to rule out the cause.
Dr. Sam, I have just couple of questions regarding this femtosecond surgery.
हाँ जी सर।
So one concern is there any chance that your laser get out of focus and damage your retina during the surgery?
So femto laser is only to cut the capsule. You don't do surgery with that.
Okay.
It's just one step. It's called FLACS, femto laser assisted cataract surgery.
Okay.
But it has not been, it is not approved by any insurance company. It is a marketing tool. We are looking forward that it becomes safer. But I did my mother's surgery. I didn't do a FLACS because I find it takes double the time. You have to go to 2 different machines, the higher risk of infection, higher cost unnecessarily. The most important thing, as I mentioned in the beginning, the lens is the least important structure of the eye. And people think that buying a costly lens or technique will give me better vision. Most important is using a good solution to buffer the cornea and checking the retina. If your cornea retina are fine, put any lens, any technique, vision will be same. It is like saying I'm buying an iPhone or a Samsung, but the tower is not functioning, and it is functioning with a 2G. There's no SIM card. So people have this concept, if I buy something costlier, I'll have better results. No. So मैं iPhone लूँ या Samsung लूँ या मैं local phone लूँ, doesn't make. So worldwide, 50% of lenses are made in India. Indian companies making it. Results are same.
Achha, another question is that some doctors suggest that in one eye you correct it for near vision and another.
I told you mismatch. I discussed that, sir. Mismatch. I told you about mismatch. But if you drive, then you may not want the mismatch. But yes, mismatch is always ideal. Half number difference in between. So when you get up in the morning, you want to see your mobile phone. At least one eye can see, and one for distance. You are not dependent on the glasses. So the aim is to be independent of the glasses. I can roam inside the house without glasses. I can see big letters. I can't read. For reading, I will require. So mismatch, it depends patient to patient, what you need. What is your need? If some person is very finicky, painter, then I can't do a mismatch because they want perfect vision. So the personality of the person who's ready to accept. Are you ready to accept mismatch? If you are a finicky type A personality, you will eat the doctor's head. मुझे मजा नहीं आ रहा, मुझे दिख नहीं रहा. So you have to judge the personality of the patient. If a housewife comes to me and says, I have never used glasses, I'm -2, I've been roaming the house, उसको मैं -1 दे दूंगा. Her life is different. Where you started from and where your ending is important.
But I feel that nature has given two eyes, that in that mismatch case you are always using 50% actually. So
that we can discuss over a cup of coffee, but that's not. Yeah, but the thing is that everything is, you are then a type A personality, you want perfection. Some persons are not even happy with one eye. Sometimes you find people coming from a rural area who have 10% vision. They deny, हमारा तो काम चल रहा है, हम तो घर में सारे काम करते हैं, हमें क्यों कैटरेक्ट करा रहे हो? हमारा बच्चा खींच के ले आया. और उसके expectations, आपके expectations different है.
And my last question is that as cataract grows and your lens thickens, I think refractive index must be increasing.
Yes, sir.
So does it mean that your number will always be reducing, positive number?
No, not necessarily. You can become myopic if the central lens is thickening and the peripheral is thickening. You can become hypermetropic, depending which layer of the lens is thickening.
Thank you.
Hello, sir.
Yeah.
I can. So I had related two questions. One, is there a cure available for macular dystrophy? Secondly, can all the cataracts be cured, especially in the case when, for me, as an instance, I had macular dystrophy diagnosed later on when I was 15. But from birth, I couldn't see with both eyes in dim light. Gradually, I lost vision in both eyes. There was an accident on top of that in one eye, and that resulted in cataract. So now doctors say that this cataract cannot be removed, and macular dystrophy they say in other eyes. So they say it's not curable.
I don't know your full history, so I want any cataract to be removed. Vision is not part in the lens. The vision is in the retina and the nerve. So I may do your cataract surgery perfectly fine. If your retina is not functioning to full capacity, vision will be suboptimal. So as I mentioned in all my lecture, lens is not important. Which lens you put is not important. What technique you use is not important. Your retina cornea should be healthy and you will get vision proportionate to that strength. That's for your treating doctor to decide how much vision, that is your expectation. If you have 10% vision or 5% vision, you may come to 7% vision. So your expectation and the doctor's prescription has to match. The problem is your expectation may be more. The doctors will feel that you are expecting more vision, they will not do the surgery. But if your cataract can give you 2% vision more, you will benefit. That doctor will take a call. As for macular dystrophy is a generalized term. Now we have hit that it is a genetic. I may have a gene defect which may have different manifestations. Like macular dystrophy is saying fever, cause of fever. So now what we are doing is we are doing genetic analysis, which gene defect is there, and then gene therapy is coming in. One gene therapy has come in the West. It's too costly, it's not coming to India, but in the next 5 years, Lot of macular dystrophies will have gene therapy. Best is to go to a genetic specialist and get your gene study done in anywhere in the world. If that gene therapy has started experimental, you can get crowdfunding done and get yourself treated. It may benefit, may not benefit, but genetic testing will help you tell you which gene is defective. And then if gene therapy comes in for that, like for muscle dystrophy, the gene therapy is about 15 crores, right? But people get crowdfunding done. My hospital has done 2 or 3 for gene therapy for muscular dystrophy. So gene therapy, funding is not a problem today. If you get your genetic study and if there's a treatment, you can always try it out.
Thank you, sir.
So I have a typical non-technical kind of. I mean, 30 years back, I saw it. The student coming to IIT, there were only 10 people with the glasses.
Yeah.
And today, 90% are with the glasses.
Yeah. So what is happening is we are evolving. Our body will evolve to the needs. So with time, we will all become forwarding. Laptop will change, our spine will change. So the eye is changing shape as per the needs. If you're looking every time towards the mobile, the eye will change shape. When I started my practice, all children had simple hypermetropia or myopia. Now 90% have astigmatism because the eye shape is changing as per your requirement. Like we call it, we have an appendix in the abdomen. It's a vestigial organ. Once we started using cooked food, we didn't require the appendix. So the eye will keep changing as per the need. If you are working for near in dim light, your eye will become more myopic, will become astigmatism. That's why we tell everybody the theory is 2 hours of sunlight will change the shape of the eye. So there are so many parameters, but you're right. Your observation is perfectly right. The number of people, as we become more dependent on the mobile and the laptop, will have more myopia and will require glasses. The other thing is that 5% were undertreated also at that time, but you are right, myopia is increasing. And in the countries like Korea and Singapore, the myopia rates have shot up to 30% because everybody is getting educated. If you are from a rural background, if you've done outdoor, you're a sports person, you may not get myopia as frequently as those who are. The reverse used to be as a kid कि बहुत पढ़ोगे तो चश्मा लग जाएगा, which is true. हाँ जी.
फैमिली ड्रामा देखो या वैसे देखो.
दो चीजें हैं. आपकी बात समझ गया. दो चीजें हैं. एक, कोई भी बॉडी फ्लूइड बनता है वो एक बेसल बनता है. मेरे मुंह में मेरा सलाइवा बन रहा है, थूक बन रही है, उसका एक नॉर्मल लेवल है. पर मुझे कुछ मजेदार खाना मिलता है तो मेरा मुंह स्टार्ट्स टू सैलिवेट. सो देयर आर 2 लेवल्स. वन इज द बेसिक सिक्रीशन, वन इज द हाइपर सिक्रीशन. तो अगर मैं नॉर्मल सिक्रीशन एक लेवल की टीयर्स की हो रही है, पर अगर मैं मिर्ची खाना खाऊंगा तो मेरे नाक आंख सबसे पानी आएगा. दैट इज अ स्टिमुलेशन. अगर मैं नाक को यहाँ स्टिमुलेट करूँ अंदर तो मेरे आंसू बनेंगे. ऑल नर्व्स आर कनेक्टेड. यू नीड टू स्टिमुलेट अ नर्व टू प्रोड्यूस टीयर्स. तो वो जो टीयर्स हैं, इमोशनल टीयर्स अलग होते हैं और बेसल जो एक बेसलाइन है वो अलग होता है. तो डिफरेंट पैरामीटर्स, इमोशनल होना से टीयर्स वो अलग है और जो बेसिक टीयर है वो इमोशनल टीयर से आपके नॉर्मल ड्राई आई ठीक नहीं होगी.
Hello. Sir, thank you for the valuable session to understanding the cataracts. I am 44-year-old from backside. Till date, I have not wear any specs. But right now, I am facing the problem for near vision only for the small letter. Thereafter, I consult with the doctor and make the lenses with pro vision. So my question is whether I need to wear the pro lenses only for the reading the books or while I am working on the system around 7 to 8 hours or entire time.
So wearing glasses or not wearing will not damage your eyes. It is just helping to make you read faster. So if I were to just squeeze my eyes, it will create a pinhole effect. I don't need glasses, right? So if you feel the need that you're having difficulty reading, use the glasses. You have no difficulty reading, don't use them. If you feel that on the PC, you are having difficulty reading, there's overlapping of lines, letters disappear, or you're having a headache trying to squeeze your eyes, then you wear glasses. It's your need and your discomfort. So glasses after 40 is not compulsory at all. It is your need. I am a doctor. I need to see the patient here, surgery. I need to see the patient here and distance. So I will have to wear progressive because I will have to work. When a banker comes to me and says, I have a problem, I have to give them progressive because they are working on the computer. They are signing document and talking to a customer. a teacher will require progressive because they have to read the book and see the student. But if you're sitting in your office and you are not seeing distant things, you can only wear a single reading glass and get away with it. So your profession, your demand will determine what you need to wear.
Actually, we are working on the table, and frequently we discuss with our other colleague on the other topics. Then at this moment, after some time, every time we need to pick up the specs, it is not possible. So what do you suggest?
So then you wear progressive glasses like I'm wearing. It has 3: distant, laptop use, and near.
I have made the pro lenses.
So progressive, if you feel the need, you wear it. If you don't feel the need, don't wear it. It's your decision. Your eyes will not get damaged if you don't wear it.
Okay.
Some people, what they do, they increase the font size of the phone and read. They increase the font size on the laptop. They make it more brighter. If you make light brighter, you will be able to read. Some people, elderly people, don't want to wear, they read it next to the sunlight window. So if you have cataract, suppose, you need brighter light. So they always say early morning we are able to read when I sit in the outside. In the evening at home and with the normal room light, I can't read. It means that you need more intensity of light to read. So you can increase the font size, but if you have to talk to everybody, then you go to progressive. For progressive is a pain in the beginning. It's difficult to adjust. Even a 1 millimeter decentering of the lens will cause headache. So if you're getting a progressive glass made, think the first 3 months is going to be difficult, and never climb down the stairs with glasses on because you will fall down. Because if I have to see stairs, the lower part is for near, this is for distant. I have to look down and then see the stairs. If I'm traveling, I'm walking regularly, I'll fall down. So after 40, you need to change the way you walk, you wear glasses. I say welcome to the 40 club because life changes after 40.
हेलो सर मेरा क्वेश्चन ये कि एक बार जो कैटरेक्ट सर्जरी होने के बाद फिर से दोबारा होने का कितना चांस है?
कैटरेक्ट नहीं बनेगा, मैं बताया था ना, झिल्ली बन जाती है। कैटरेक्ट तो गायब खत्म कर दिया आपने, वो निकाल दिया वहां से।
इन केस ऑफ जो हाई डायबिटीज होती है, मतलब उसके अंदर
नहीं, अलग लेयर है ना। जैसे कैमरे की फिल्म है, कैमरे का लेंस है। कैटरेक्ट एक सिंपल सा कैमरे का लेंस है, रेटिना अलग लेयर है। तो हर लेयर है। लोगों को गलतफहमी है कि एक ऑपरेशन से 1000 बीमारियां रुक जाएंगी या मुझे कोई प्रॉब्लम नहीं होगी। तो हमारे पेशेंट कोई किसी को होती है 10 साल बाद फोन कर, डॉक्टर साहब आपने सर्जरी की थी, आज आंख खराब हो गई है। तो अगर मैं किसी का ऑपरेशन कर दूं, वो 10 साल तक सारी बीमारियां उसी जड़ से निकाल देता है। कैटरेक्ट अलग है, रेटिना अलग है। अगर आपको मैंने एवेलुएट नहीं किया, मैं आप मैच्योर कैटरेक्ट लेके आए, मैं आपका रेटिना नहीं देख पाया और उसमें डैमेज है, जब मैं कैटरेक्ट करूंगा बाद में आपकी विजन नहीं आएगी। तो जिस पेशेंट का मैं पर्दा नहीं देख पाता हूँ ऑपरेशन से पहले, उसका कैटरेक्ट इतना एडवांस होता है, उससे मैं बोलता हूँ कि मैं आपकी विजन गारंटी नहीं कर सकता जब तक मैं आपका पर्दा नहीं देखूंगा। आपका कैटरेक्ट एडवांस है, विजन आ भी सकती है, नहीं भी आ सकती है। अगर पर्दा कमजोर होगा, उसका अलग ट्रीटमेंट होगा।
Sir, I have two questions.
Yeah.
First of all, it was an excellent talk and presentation.
Thank you.
Sir, like there are different eye drops in the market. For instance, carboxymethyl cellulose, sodium hyaluronate, and even polyethylene glycol also. So how do we choose this kind of drops for different patients? And my second question is there any role of omega-3 fatty acids for dry eye?
Okay. So you're very well versed, you know more than me. Everything works to a certain limit. So every drop has a pH. Now normally the eye tears is 7.4, right? So when you have dry eyes, your pH gets altered. That's why you have a stinging sensation when you put certain drops. So the thicker the solution, the longer the retention. The less the viscosity of the solution, you will have less blurring. When I put drops, I will have blurring for a minute or two until it spreads out. If you have dryness which is mild, then the thicker viscous fluid will work because you just want lubrication twice or thrice a day. And the retention time is 1 to 2 hours. If I have severe dry eye where I have to put 8 times a day, then I would want a higher viscous solution, a thicker solution, and sometimes even a gel to work longer. So based on your symptoms, your doctor will prescribe. Some are happy with 1, some are happy with 2, but all work equally well. Some have retention time, some don't have. So the thing is that can I bring back nourishment to my tears and will they increase? Now you have to understand that dryness is not decreased liquid. So the eye has three layers. The tear film has three layers: mucus at the bottom, aqueous layer, and an oil layer which is produced from the oil glands and the lid margin. Every lash of the body has an oil gland. So if your oil gland is blocked, your evaporation will be higher. So, and when suppose you have a dryness because of this irregular surface, all things are there, but your surface is irregular. Like you have a car wiper, but the car blade wiper is rough. It is not wetting. It's giving dry spots. So then we work on the lid skin. If you have an oil gland which is blocked, I'll say hot fermentation. So the omega-3 say it helps the oil secretion, but it is only 1% of the job. You have to work at multiple fronts and then explain. So first is humidity control, and no antihistaminics, don't splash, and wear protective glasses all the time so your dryness goes down. And take a break, because all of you use PC, take a break, 55 minutes, take a 5 minutes break so that your dryness goes down.
Hello, sir. Thank you for the informative session.
Yeah.
So, I have two questions. First of all, like I have observed that when I apply a particular cream on my face and also on my eyes, then my vision somehow gets affected. So, these kind of things, do they cause some permanent damage to the vision?
No, what happens is that every, say a soap or shampoo has a chemical. So people who have dry eyes, we say don't apply any chemical around the eye. They always complain, after a bath, my eyes are red. So we tell them use baby soap, baby shampoo, or no tear shampoo. So any chemical you use will go into the eyes. Even if it's in your hand, you rub your eyes. So 1 inch around the eye, any chemical. So the biggest problem is telling ladies not to apply kajal because block the oil glands. We become unpopular with them. So any cosmetic you put at night must be washed away because those granules will block the pores and the oil will come. So normally what we do is when we see a person for dry eye, we avert the lid. We turn the lid apart and see the skin inside. Sometimes you see people's kajal is stuck for days. They say we not applied kajal for 5 days, but we see the granules. So normally tear will wash away the granules of. So any cosmetic will cause a problem in the eye. If you are sensitive eyes, avoid cosmetic, avoid certain creams around the eye. Use baby soaps, baby shampoos, baby creams.
Sir, can it cause permanent damage?
Depending what the chemical is.
Okay.
See, the problem is that a lot of medicines are on the market, and since in India our pharma industry is not very well controlled for quality control, even if the pH is not proper, it can cause blindness. So one company's pH was there and the patient became cornea blind. One company was exporting to America, they didn't have quality control, it caused infection. So every drop can have bacteria, have endotoxin. It is dependent on the quality. India pharma industry doesn't have control. We don't have quality control. So that's why when I prescribe, I tell everybody I prescribe a company which exports to America will have some FDA control. And I never change drugs or any company offering me for a surgery, use this solution, because I know if I'm happy with one, if it is costlier, keep using it, because we don't know what the pH is, what are the endotoxins level are there. So since you all know physics, chemistry, every solution has bacteria. Every water has bacteria. When we sterilize them, the gram-negative bacteria releases a chemical called endotoxin. So every company which make tears or any injectable drug or anything are supposed to check the endotoxin levels. Even a sterilized bottle can have endotoxins. So sometimes what happens is if you give a patient intravenous saline, they have shivering. It means that bottle has endotoxins. So every chemical, the biggest problem in India is sterilization. For surgery, I have to use at least 10 vials of different solutions. How they are sterilized, how they are this thing, the onus is on me, because tomorrow if the patient gets infection, the doctor is to blame. So we are always waiting. We have this adverse reaction in our WhatsApp group. This company, this bottle has given reaction. Stop using that bottle. So India, all the pharma, all the cosmetic, it will take time for them to have quality control.
And so one more question.
Yeah.
Sir, I see after images. Like for example, I'm looking at something, then I would see the same thing in fluorescent colors here and there. So is it related to vision or something else?
No, depends on the power of your glasses. If you are seeing from the periphery, you will have a distortion if you have a cylindrical power. If you have dry eyes, you'll see after image. And normally you can also see after image depending on what you focus. Say, suppose I have my finger here, right? I'm looking at my finger, I'll see two of your images. If I look at you, the fingers will be two. So depending where you are focusing, the other image will be double.
So this after image could be
normal.
Okay, thank you.
So,
yeah,
what are the options do we have to cure the damaged retina?
No, retina is a part of the brain, right? So you can reverse a disease and control it, but you cannot regenerate the retina. With the day I can regenerate the retina, I can regenerate the brain also.
Hello, sir.
Yeah.
I want to know what is the effect if someone's cornea is steep? Does it has any effect on the vision, or later on it will have some effect?
Basic physics principle, any steep will cause myopia, because the steep will cause you to focus early. Your focal length will be smaller, right? So you need a negative lens to diverge the image.
So it will not have any effect on cataract or anything else?
No, it will have an effect on your glasses power. Na? As I mentioned, the dioptric power of the eye is about 60 diopters, 44 in the cornea, which is fixed, and 16 in the lens. Now, if I have an eye, depending on where my lens is positioned from the cornea, is it 2 millimeter or it is 2.5 millimeter, the distance of the lens from the cornea. So you have three factors: the length of the eyeball, the corneal curvature, and the lens position relative to the cornea will make an effect on your vision. It's a refractive error. So if you have a steep, I have a flat cornea, but my eye length is bigger. So God is compensated for both. So depending on how your structure is, overall, it's a mathematical. You people know better than us. We learn from the engineers only about optics.
Okay, thank you, sir.
Any more questions? Please go ahead and ask.
Hello. Thank you, sir, for the talk. So my question is like, sometimes people do not want to get the cataract operation done. So how will it affect their life further if they do not? What is the right time to do that? And sometimes they think that we should do the cataract operation during winters. So your thoughts on this?
So one thing is that we have a Snellen chart. If you ever been to a optician or ophthalmologist, there are 7 lines from 660 to 6. So depending on the need. So 7 lines is 6 by 6 perfect vision. 6 by 12 is 5 lines. At 5 lines, you get a driving license, right? So if you have 612, you are eligible for a driving license. If you don't want to drive, not a professional, even with 636 vision, an old person can lead a normal life, can eat, go to the bathroom and eat. So it is a patient's requirement. Are they feeling handicapped? And then get the surgery done. It's never an emergency. Only if the eye pressure is going up 1 in 1,000, it's totally mature, totally blind cataract, then this thing. The only thing is that as the cataract gets more hard and harder, it requires more time doing surgery. The ultrasound will be used more during surgery, causing edema to the cornea. So for us, technically, the earlier the cataract, it's much more easier to do, less time. So surgeon will push, it's easier for me, you're going to be more happy, but patient can decide at their own when they want the surgery. The olden days, when there was no ACs or coolers, people in the rural area have a right justification that in summers they sweat a lot and they feel that the sweat will go into the eye and cause infection. Certain people felt that the infection rate goes higher in the rainy season. Definitely your skin infections go higher. So some people feel that I am not sitting in an air-conditioned environment. I will wait for a environment where I am comfortable. I have no itching. I have no watering. So they are right, the older tradition. But if you live in an air-conditioned house or an air-cooled house, then temperature is the key factor any season would do.
Hello, sir.
Yes.
Thank you for the session. What are the preventive strategies for the cataract, or it has to happen as it is the process, aging process?
So it's an aging process. It has to happen. By 100 years, some at 90, some at 80, some at 40. So first factor is the genetic factor. If your parents have had an early cataract, you will have. Second, exposure to outdoor activity. So farmers will have a earlier cataract. You'll find that the people who do farming or labor, their skin also ages faster, right? So the aging occurs with UV light. That's why goggles are protected. The commonest factor is diabetes. Diabetes predisposes to cataract 10 times more, and cataract is the commonest cause. I tell everybody your HbA1c determines your cataract. So cataract and the use of steroids. So steroid drops are commonly used for allergies. In India, 80% of the medication is given by over-the-counter chemists because people don't have access to. So the chemist decides. Even in COVID time, the chemist is giving all the medication. So steroid is used as a wonder drug for fever, for eye infections. So you can have complications. My friend was an eye surgeon. In his postgraduate, he had allergy. He kept putting the steroid. He didn't check. He lost his eye. So glaucoma caused by steroid and cataract. So steroid use is so I tell all the physicians also, if you're giving steroid for bronchitis, please get your patient's pressure checked if he's using steroid for more than 1 month. So steroids cause BP, diabetes, and glaucoma and cataract. So if somebody's on steroid, long-term steroids, over-the-counter steroids, and nowadays a lot of gyms are selling steroid with protein supplements for bodybuilding. So people come to us, we use supplements. We bought it from the gym instructor. They're all putting steroids in to get good body. Even Amit Khan agreed that for his body, he'd use steroid for his movie. So I don't think that is the right way to make body using steroids.
So I think if you have more questions, please ask, or we wind up the session here. Sir, I have one question for you. Yes. Like many genetic syndromes are associated with pediatric cataract. So how do we treat those children with cataract?
So it's important to understand that the brain requires early rehabilitation. So if a child is born and I were to just close one eye for 3 months, the brain software will malfunction. So what we call is that the child must see within 3 months. If a child is born with cataract, we even do at day 5, day 6, if the cataract is total. So to rehabilitate, if I were to put a plaster on my hand for 6 months, after 6 months, my hand will require physiotherapy. It will take 6 months to work. So brain requires continuous stimulation. It's called a lazy eye or amblyopia. The brain starts to malfunction. So that's why we say every child who goes to school must get glasses made, because sometimes one eye has a number, other eye doesn't have, and this malfunctions and we never able to get the vision back. If a child comes to me with one eye poor vision, we patch the other eye, force the child to see with the other eye. I'm a right-hander. I want to work with the left. I'll put a plaster here for 2 months, right with, then I'll able to. So the brain wants balance of both the eyes. It's important that we give glasses to a child. In India, what happens? After 40, everybody starts wearing glasses. It's not necessary. They must force their children to wear glasses before 8 years of age to prevent imbalance.
And the other question is, sir, that if the cataract is in both the eyes, can we operate it at one go, or should we keep a gap between the surgery?
So there are two things, sequential and simultaneously. If a patient is high risk, I'm doing under child anesthesia, or patient has mental retardation, I'm doing under general anesthesia. I may do both eyes, but it's important that we consider both eyes separately, and separate set of instrument is used, not the same instrument, because there's a 1 in a million chance of infection. If you're doing surgery at the same time and you end up having infection, you lose both the eyes. So it's important that one eye heals completely. The risk of infection doing simultaneously is there. Otherwise, you can do, but if you do both eyes, we dewash, new machine, new instruments, then do the surgery.
Okay, any more questions, or should we? Thank you so much, sir, for your patience, and we have really learnt a lot. It was really an eye-opener for us, sir. So thank you so much on behalf of everyone.
Thank you. Thank you very much for your patience.
Thank you all for your encouraging questions and participation. Now, to formally express our appreciation, I request Professor Beam Singh, Department of Electrical Engineering, IIT Delhi, and Dr. Mahesh Sagar to felicitate our guests with a token of gratitude. Please join me in a warm round of applause. Thank you, sir. Thank you, Dr. Sagar. Thank you once again for this session, and we look forward to see you again in the upcoming future lectures of Aarogya Health Lecture Series. Thank you so much.